Hello and welcome to the GAP MASLD Community Network meeting with Sarah Dawkins. My name is Danielle and I'll be your moderator this evening. I'm joined here virtually by our presenter. There will be an opportunity for questions at the end of the presentation or during the presentation. And at this time, I'll now pass it over to Sarah.
Thank you. Thanks for inviting me to be here. I'm excited to talk about something that is very important and really transverses all types of healthcare and disciplines. Let me see if I can get my slides to go. Okay, so this is me, and you can use this QR code to record your attendance. Will this be presented later?
No, but I've recorded.
Okay. So we're going to be talking about lifestyle management, especially around metabolic dysfunction-associated steatotic liver disease, or MASLD, just for the sake of time and articulation here today. So we'll start with a case study. So this is Albert. He is a 65-year-old patient with obesity referred to you for elevated liver tests. With abnormal imaging, with an abdominal ultrasound, notable for increased echogenicity consistent with hepatic steatosis. He is Hispanic. He has a BMI of 29. He does not have any recent alcohol use. He discontinued in his 20s. His past medical history is notable for type 2 diabetes, hypertension, and hyperlipidemia. His laboratory findings, his triglycerides are 89, his HDL is 41. He has a hemoglobin A1C of 7.2%. An ALT with known elevation for at least 3 years, or about 3 years, 1 to 2 times the upper limit of normal. He has had a serologic evaluation for other types of chronic liver disease, which was negative. On physical exam, you note abdominal adiposity, and there's no stigmata or evidence of advanced liver disease or portal hypertension, and he is overweight. So with all of this information, you can make a diagnosis of metabolic dysfunction-associated steatotic liver disease. So here are his labs. His ALT is 43, AST 38, and his platelet count is 170,000. You get a FIB-4 score using a clinical decision tool to help guide us through the pathway of using NITs. So this is the AGA clinical pathway for MASLD. So identifying patients at risk for MASLD is the old term, MASLD. A patient who has 2 or more metabolic risk factors or type 2 diabetes or steatosis on any imaging modality or elevated liver tests. And our patient, Albert, meets these criteria. Even if he just had diabetes, that would be criteria to screen. So he got a FIB-4 test, which was 2.22. And so he is considered an indeterminate risk. So next step would be to obtain further imaging. So Albert received a FibroScan, and he had a median liver stiffness of 6.7 kilopascals. So he is considered low risk for having advanced fibrosis. So according to this guideline, we need to repeat non-invasive testing in 2 to 3 years, unless he has a clinical change. And then we focus on lifestyle modifications, which will be the main topic of this talk. So this is a great slide showing the MASLD continuum of showing bland steatosis or MASLD, which can progress to steatohepatitis, which is steatosis with inflammation, with ballooning, which can later develop into fibrosis, later cirrhosis, which can increase your risk for hepatocellular carcinoma. So being overweight or having obesity, type 2 diabetes, or 2 or more metabolic dysregulations can allow this pathway to happen and to allow this the progression of fibrosis. So what are the risk factors in pathogenesis? So in addition to all the metabolic conditions that can lead to metabolic liver disease, this kind of highlights the genetic factors in MASLD. The PNPLA3 is likely the most robust and consistent genetic risk factor for MASLD. So it does impair triglyceride breakdown in liver cells, which increases hepatic steatosis deposition. So it's very strongly associated with hepatic steatosis, fibrosis progression, and then liver-related mortality. The TM6SF2 it reduces the LDL secretion, so it allows more steatosis to retain in the liver, and is associated with increased hepatic steatosis. And then finally, the MBOAT7 or MBOAT7 alters phospholipid remodeling, so that leads to increased hepatic inflammation and stress. So all of these factors, in addition with the dietary factors, cause steatosis and allow for that progression in fibrosis. So a diet high in saturated fats, high in inflammation, or increases inflammation. A diet high in fructose, like the sodas here, can increase de novo lipogenesis and reduce fatty acid oxidation, and also just increase oxidative stress. And then the omega-3s should be increased in the diet, and a diet high in unsaturated fats. And then omega-6 deficiency should be avoided, but it's not recommended to use supplementation for MASLD. So the obesity pandemic can cause type 2 diabetes and MASLD. And the slide says the elephants in the room of MASLD are obesity and diabetes. So the management of metabolic liver disease must involve control of diabetes and reduction in body weight. So the management of MASH, it really is a balance between nutrients and energy, and it's crucial in the development of MASLD and MASH. And central obesity is the main promoter of insulin resistance and pro-inflammatory signaling. And I just want to make a note that GLP-1s are a hot topic these days, and I know there's a lot of studies based through clinical trials, but it is not part of lifestyle modification, so won't be included in this presentation. So back to Albert. Upon dietary questioning, he explains that he eats a traditional Cuban diet consisting mostly of rice, beans, pork, corn, beef, and plantains. So how do we discuss diet with our patients? And I can, Elizabeth, if you want to chime in, or I can kind of talk about dietary recommendations and how to approach this with patients. It can be a sensitive topic. And I think especially in Albert's case, we have to be very sensitive about his cultural preferences. I mean, Hispanic diets of rice, beans, pork, plantains, we have to be very sensitive about how we approach
Sure. Yeah. I mean, especially this is an era where we're also working so hard to appreciate how diversity is diverse, right? And so it's not just, for instance, this diet. We have a lot of Filipino patients that have the Filipino diet is very carb heavy. So how do you approach it sensitively without dismissing this is so important, it's a part of your life and your culture, and how do you change? And I think it's really difficult. Although what I've also found is most people who have these carb heavy diets know they're bad. By the time they get it, I mean, the number of times I'm like, how about the rice? And they're like, yeah, I got it.
A lot of rice, like, yes. So it's, meeting patients where they are and kind of doing some motivational interviewing almost around like, why we're making these recommendations with the rice, because I think some things like rice, you wouldn't think that they could be, the high carb diet. How does that affect metabolic liver disease and diabetes, et cetera? So, but I think it should all be individualized and taking into the account of their like social, their cultural, also financial context, because eating healthy can be expensive and going to the grocery store is expensive. So, we'll review in another slide, but the Mediterranean diet is the mainstay that I recommend to patients. But it really needs to be a sensitive conversation. It needs to be, approached in a sensitive manner.
Right. Well, and I think, meeting people where they are also involves working with the parameters that they live in. So it's not necessary, I'm interested to see how we talk about the Mediterranean diet and how it meshes into, because it's the components, I think, pretty much of the Mediterranean diet that make it healthy, right? So what are the substitutes that you take from that and apply to
Right.
different types of diets, right? So, and also, can you just eat less? That was one of the other
Right.
things. You can eat the rice, but can you eat less of it?
That's what I usually talk about is, because it is mainstay of your diet. So just making that portion size a little bit bigger, maybe making the protein size a little bit larger or the vegetable size larger, to kind of adhere to that Mediterranean diet.
And certainly you don't want to, you take elements, I know from I know one of the successful weight loss programs that I've had people talk about and know friends who've done is the weight loss is Weight Watchers. And one of the things that Weight Watchers talks about is the importance of not depriving yourself of what you love, because if you do, it's backlash and you just get angry and get irritated. So that would seem to apply in this situation as well. You don't want to take away the things that make you feel good and connected, because that'll just be it won't work, right? It'll lead to the backlash against, I can't do this anymore. It's frustrating. I'm trying to help make positive forward change instead of creating goals that are appropriate. It would be inappropriate and unreasonable to say, you must eliminate all carbohydrates, all tortillas, and all rice from your diet.
Can't do that.
Not gonna happen.
And I think it's also important to approach it with a family and have family support, because often they share lifestyle changes together. And so if it's one member of the family and there's 4 other people in the house, sometimes I talk about it as a family change. The family can make these changes together and in like an actionable way. I don't want to give advice that's out of reach or so. That's usually how I approach diet with our patients. So lifestyle modification, dietary changes, and exercise have been the mainstay of MASH until resmetirom approval. So we're not talking about resmetirom today. And weight loss, as most people know, is directly linked to improvement in histologic outcomes. So modest weight loss, about 5 to 7%, can improve steatosis, but that 10% is where we start seeing regression of fibrosis. So that's usually what I recommend to patients, is to aim for a 10% reduction in your body weight over 12 months. And this is just a good diagram of just showing the way a healthy liver with the Western diet and lifestyle risk factors, sedentary lifestyle can lead to metabolic liver disease or steatotic liver disease, and then the reversibility of with aerobic and resistance exercise with lifestyle changes in the Mediterranean diet can allow for reversal of fibrosis and resolution of MASH. And this is all individualized. So the efficacy of diet and exercise may be impacted by genetics. And so I think that's also important to note as well. And I think going back to this, sorry, I'm going backwards, is I like when I'm discussing lifestyle modification with patients, especially if they do not have advanced fibrosis, they have stage 1 or 2. It's so important that they know that it's the reversible condition. And so by focusing on these lifestyle changes, that this is something that can be reversed. And I hope that motivates people and gives them extra push to focus on these things.
Sarah, I do think it's important to say it again and again and again, because I mean, the reason that GAP is putting out this whole series on lifestyle modifications is because it does make a difference. And we do, I think, dismiss or diminish if it's going to be successful or how important it is. And it gets it's like, oh, it's never going to happen, so why bother talking about it? But it's important, and that's why it's worth it to spend a whole 30-minute talk right now to look at how important it is. And I need that, but I need that affirmation as a provider too. I think saying it to each other, like, this is an important thing, we need to keep doing it, is because we do give up and we get busy in the day, and we know it's hard to make change like this. So where do we focus our energy? on other things. Like I can write a script easier than I can get somebody to exercise.
Exactly. And
but it's just as, if not more important, the best data,
so important.
the best data for what improves MASH is diet and exercise and weight loss. It is better than any drug right now. It's better than the resmetirom data. It's better than, I don't know, probably going to be better than, you know, what we have for the GLPs coming. So this, and that's old news. So and it applies to all of them. So I'm not to take your podium, but I think you doing this, don't diminish the importance of this. Let's keep
exactly. And I think when you have 30 minutes with a patient and especially if they have advanced fibrosis, you're talking about HCC screening, you're talking about all of the liver related healthcare maintenance. And then you're like, oh, I've got 5 minutes left. Let's talk about lifestyle modification. So I give myself a little grace because it's not going to all happen in one visit. So with the follow-up visits, just keep talking about it. You know, chip away at that topic because continuing to talk about it will it reinforces how important it is. So I try to give myself grace because sometimes I don't have the full time to talk about the diet and exercise, but I do try to make note of that for the next visit. So just make it part of your checklist, you know, as you're seeing the patients. It's so important. So lifestyle modifications, and so people say, well, what kind of exercise should I do? You know, what should I do? So previously I've told patients 150 minutes of physical activity, get your body moving, get your heart rate up in a week. These are 2 studies that I found really interesting. So the first one was around high intensity interval training, and that is such a hot topic these days. And this study, it was done in adolescents, age 13 to 18, with risk factors for MASLD. Some of them did have MASLD. Some of the participants did have MASLD, but it did not show that it was effective in reducing in liver fat. So by the intrahepatic triglycerides, it did help in like total cholesterol and lowered 2-hour glucose and LDL. So this study was only done over 4 weeks. So one of the limitations of the study or opportunities for future studies is was this just too short of a study to really see the benefit of HIIT training in the MASLD population? So I have not counseled against my patients who want to do HIIT because I think, hey, if this is something you're going to love to do and want to do, then maybe give it a try. But according to this research from 2023, the intrahepatic triglyceride content was not significantly improved compared to the control population. But the other study was a large meta-analysis that looked at combined either aerobic training, aerobic and resistance, or resistance training. And it really showed that combined aerobic and resistance offered the most comprehensive benefit. Aerobic exercise alone was most effective for improving ALT and boosting HDL, but resistance training also excelled at reducing AST. So overall, pairing the aerobic with resistance exercise was a great strategy for patients with MASLD. And so I think the resistance part is important because it requires less energy consumption. And so especially for patients, elderly patients, or patients who don't have, who aren't able to participate in as many aerobic workouts, that resistance exercise is also really great. So I've started encouraging patients to do this as well, rather than just aerobic exercise.
No, that's a great point to just look at, because we keep talking about you got to meet people where they are, right? So this is a great point. You got to adapt what you tell people to do to what's a realistic goal for them. And I hadn't even thought about really like thinking about like, yeah, they're just not going to be able to do cardiac activity. So we need to remind them that for this, I mean, not that this is, you know, end of the world data, like earth-shattering data, but it's supportive that the thought is move more, whatever it is, if you're moving in place and not moving against gravity, just moving with strength training and not doing cardiac, that's still good. Any exercise, and I think that's any movement is good. And the other thing I think we should keep in mind with stuff like this when we're trying to talk about data quantification of exercise in MASLD, it is really hard to do exercise impact studies. So the fact that there's not this huge body of data that says exercise makes a difference is not a reason not to recommend it. I'm just going to say, Courtney, I know you're done over at Cone. Feel free to turn. Sarah and I are just kind of having a conversation. So if you're in a place where you want to join us, feel free to just jump in here and join the chat. So,
yeah, hi Courtney, thanks for joining. And I also meeting patients. I like that you brought up meeting patients where they are, because gyms can be expensive. So, I mean, not everybody can go work out at a gym, or they may not live in a place that they feel safe to walk. So just kind of assessing what would be a reasonable goal for them, for these patients who have, who you're recommending to exercise. Do you have a safe place to walk? If not, I usually recommend people go to the mall or go to Walmart and do laps around.
Right.
Do you have access to a pool? Do you have access to a gym? So just meet people where they are and try to give recommendations based on their abilities. And then the MASLD friendly diet, which is, of course, calorie restriction to achieve weight loss is mainstay, because weight loss has been shown to reverse liver fibrosis and help with resolution of steatosis, promotion of ketogenesis. And then the Mediterranean diet is just widely supported across multiple guidelines as the primary lifestyle intervention. So I usually talk to patients about the Mediterranean diet. I give a printout. People have questions about the Mediterranean diet, so try to answer questions. I also have a smart link for a toolbox a wellness toolbox that they can use for recipes. I talk about perimeter of the grocery store, so lean meats and proteins, chicken, turkey, fish, diets high in unsaturated fats, minimizing saturated fats, and then limiting fast food, fried food, foods high in saturated fats, and then anything essentially that comes out of a box or a bag in the middle of the grocery store. So try to make it, try to keep it as simple as I can, but things that they can latch on to. The other thing that's not on this list that I recommend to every patient is coffee. So I recommend caffeinated coffee 3 to 4 cups a day if they can tolerate it. We talk about that as part of the, I kind of loop that in a diet, especially if patients are drinking caffeinated sodas. That's a good way to switch. So finding ways with patients that they can integrate the Mediterranean diet into things that they love is important. So Albert, let's go back to Albert, our patient. He returns to clinic for labs, and there's no improvement in his labs. How often do we see this happen? All the time. He says that he has not started exercising, but he has been trying to cut out soda. So how do we work with patients to create behavior change? I think for this patient, I would applaud him in his cutting out sodas, because I always try to start with some positive reinforcement, because making these lifestyle changes is hard. And so Albert has already tried to cut out soda, and that can make a big difference. I don't know what the time frame was for follow-up for him, but I would start, I would revisit the diet, and I would revisit kind of see what his barriers are to exercise and see if we can overcome those. But I think the motivational interviewing and the positive reinforcement on what he is doing is kind of the mainstay of how I try to create behavior change. I don't know if Courtney or Elizabeth, if you have anything else to add.
Looks like Courtney's put a comment in the chat. It's a great question too. Do you create a handout yourself on the Mediterranean diet, or do you use a resource from a specific organization?
It's a good question. Thank you. I was not paying attention to the chat. It's part of our organization that I hand out, but I also have a dot phrase for like a wellness toolbox, and I'm happy to share that later as well. Yeah. anything else about behavior change? What works in your clinic? What you find? I mean, this is something that
I have to think, I think part of this is we all know this would help to talk to people about this, but I think it might be one of the reasons that I know sometimes I don't go into this because I just don't want to accidentally dive into all of the other functional complaints that they have. So shutting down, it sounds terrible, right? But sometimes having these conversations where we're talking with people, we're trying to focus them on something that makes a difference when they're so focused on their IBS that they have, because it's impactful to them, and
very true.
how to, whatever their visceral hypersensitivity or their functional pain is, and how do we get them to focus on what's impactful. And so I think that there's a part of me that doesn't do this when I don't do it. It's because I just know if I open the conversation, I'm not going to get out the door.
And when you have a full panel of patients, it impacts your whole day. And so I hear you, and it's a double-edged sword.
Yeah, it's hard to remember this is worth it to do. It's worth it. It's worth it. So yeah. It looks like you're almost at time. You only got 2 more minutes.
Yeah, I have one more slide. So the exercise and diet adherence scale is the studies posted below to validate this system. Does anybody use this, the exercise and diet adherence scale? I do not use this in my practice, but it is voluntary, and it's a questionnaire that occurs at baseline before the intervention and after 6 months after their lifestyle changes, and it gives the provider an idea of the adherence to the lifestyle changes. I am not using in this practice. It does say that there's 33 criteria to be that were checked to monitor daily exercise and calories intake. So I do need to kind of investigate how long this would take for patients to fill out before and after. I think there also could be a little bit of bias also as far as what patients will admit that they're doing. So I don't, Courtney, do you use this in your clinic? Elizabeth, have you heard of this?
No, I don't. It is not something I know of. So I'm going to make sure I look it up and see what it is.
Yeah, I didn't know about this either. It seems like it would be very helpful though.
Potentially,
yeah. I think it could help guide. And so there's 3 criteria, and it will say like based on the score, if they are not adhering, if they are adhering somewhat, or if they are compliant with the lifestyle recommendations. So I'm going to give it a whirl, and I think, it could help you with, further decision making about next steps for the patients as well.
Well, I think part of this is quantification, right? We ask motivational interviewing questions to say where are you? What have you done differently? What could you do differently? So this might be a good tool to say, I see that you show here, depends on what the questions are. It could be something to help you with your conversation.
So that's time. So I appreciate everybody's thoughtful input and comments, and this has been great. And I think Elizabeth made a great point that we need to keep talking about this. And as providers, we get fatigued. Like diet and exercise and weight loss. Again, let me talk about it again. But it's so important, and it's really impactful to these patients that we care for.